Welcome, EGP learners. It is the 17th of April, 2025, and Gandhi and I are about to update you on what's been happening in the world of general practice over the last 2 weeks. We've had a little bit of a change of pace from all of the big announcements that came out earlier in the year, and we'll be looking at some of the perhaps slightly smaller, but still very interesting stories that have caught our attention in the general and GP media over the past 2 weeks. So let's tech enhance your primary care and learning. Hello, EGP learners, and hello, Gandhi. How are you doing?
I'm good. Yourself, Andy?
Yeah, not too bad. Looking forward to today's episode, actually. There's some interesting stories here that might generate some good discussion, I think.
Definitely. I know we've got some interesting things, particularly a big headline that came out today that may not be as big as people think when you actually get to the detail and things, but lots of cool stories that are hopefully going to keep people updated in terms of what's happening in general practice, navigating the chaos that comes along. And in addition to that, we've got some news about what's coming up in the next couple of weeks for those of you who follow the channel on a regular basis, and some cool information to help you navigate all that as well, haven't we, Andy?
We have. And as ever, we've got a few people watching on YouTube, and other platforms are available. So please say hello in the chat and contribute, interact with us. We'll bring worthy comments onto the screen and have a think about them. Be happy to answer questions and so forth. So let's let people know what we're covering today. So over the course of this evening, we will be covering a plan for GPs to keep millions out of hospital. This is a story that hit the mainstream media. It's the advice and guidance enhanced service, with mainstream media keeping up with the rest of us in general practice. But we'll be having a little talk about that because that's big news at the moment. ICBs have been told to mine new GP practice data set for unwarranted variation. So that's an interesting story about how our data might be used in the future by ICBs. There's another story about an NHS-specific barcode to ensure prompt delivery of appointment letters. I think that's something which might be universally welcomed, and we'll have a little look into what those plans are. We've also seen that there's a timeline for the BMA and what they expect in terms of contract negotiations for a new GP contract next year, or perhaps even after that. Another large piece of primary care general practice assets, resources have been snapped up by a large private company. So we'll be talking about that deal to do with GP Premesis, and maybe reflecting on the other deals that have gone through this year and in the past few years, with bits and pieces of general practice being bought up by big business. And finally, we will be looking at the numbers of ARRS GPs that have been hired since October, because NHS England have released some data about that. And of course, we'll be talking about some opportunities to get involved with conferences and activities that we have planned through EGP Learning. So how's that sound, Gandhi?
It sounds like a great episode. I know there's loads that we're covering, but I'm just trying to make sure we capture all of it in the promo and stuff that we've got ready for everyone. So, yeah, I think we're probably better we get started though with it. And the big news story that came out today is very much around this whole concept that there's going to be millions saved in terms of keeping people out of hospital, isn't there, Andy?
There is. So this is probably the mainstream media catching up with something that we've been talking a lot about in the past few months on EGP Learning. And this is really driven by the advice and guidance enhanced service that was announced as, I think it was announced actually before Christmas, if I remember rightly. And then it formed part of the announcements of the new contract negotiations, and then it was released in its own right as an enhanced service a few weeks ago, and we covered that on EGP Learning. But the mainstream media have caught up, and we've picked one of the articles. Could have picked any, but this is from the BBC website. It's talking about how GPs will work more closely with specialists to access expert advice quickly for patients with conditions such as irritable bowel syndrome, menopause, symptoms and ear infections. The idea is to save time and stop masses of people having to head to hospital for unnecessary appointments. This expanded scheme is part of the government's plan to cut long NHS waiting lists and create extra appointments for patients. It's called Advice and Guidance. The scheme links GPs and hospital specialists before patients are referred onto waiting lists, so that tests and treatments can be offered in the most convenient place. So there must have been a government press release about this, or briefing to the press to follow this story. So, I mean, Gandhi, we've looked at the advice and guidance enhanced service and talked about it previously. Do you think it's going to live up to this hype?
Simply put, no. But it is interesting because I think, rewarding general practice for work it's already potentially been doing in several areas and possibly looking at doing to navigate patients to the right place for the first time. I don't have a problem with that. I think the challenge as to whether it will achieve this huge objective of keeping millions out of hospital. I mean, we talked about this before in the actual original episode, that it's based off some studies that show that potentially 50% of people don't go to hospital, but those studies are really small. So when you try and factor that across the entire country, is it going to live up to its expectations? I don't know.
Yeah, I don't know. I mean, they say 2 million people might be helped. And I guess actually what we know about this scheme already is that there's a payment of £20 per patient. So I guess actually
Mm-hmm.
you could get 4 million episodes of advice and guidance out of the 80 million that this scheme is capped at.
Mm-hmm.
So actually a lot of people might benefit from it. But you're right, Gandhi, a lot of this activity already happens. It's just it's not happening within this enhanced service structure. So actually this will be paying GPs for some activity that's actually already happening, but that isn't currently rewarded.
Mm-hmm.
I'm not sure it's going to be as revolutionary as they say, but I guess many GPs would welcome being paid for something which happens already. Would you say?
I think the concept is great, and I think the mechanism will definitely have some impact in terms of what happens. But whether it will achieve the objective of what the government wants to keep people out of hospital, that's the part that's really hard to understand at this stage. And I think that's the part that we just need to have a better clarity in terms of what it will look like. But the problem we've got with this is that even though this is the news story, it's meant to be up and running already, and we don't really have the details as to what that looks like. So, for example, there's no coding to help understand how this works. The ICBs are meant to have come to the practices already to ask them if they want to sign up to this service because it is optional. I don't know about you, Andy, but I've not seen an email from our ICB about this.
Yeah, I mean, I've been on leave for the past week, but I'm not aware that anything's come through. They were supposed to invite practices by the 15th of this month, I think, 15th of April, and have people signed up by the 30th of April, by the end of the month. And I'm not aware that the arrangements have been made about how this will work. And as you say, this actually includes payment for activity that may have already happened within this
Mm-hmm.
tax year. So I think if people are using advice and guidance out there, please make sure that you're using some Snowbed or Read code that you can go back and then search for and apply the correct code, which will be pulled out through CQRS for payment of this. And that's provided you sign up, because it's an optional enhanced service. So
Mm-hmm.
it may be, and I'm not sure that we've seen sort of details locally, but maybe that sort of practices and LMCs feel that it may not be appropriate to sign up. Ultimately, I guess the devil will be in the detail, as you say.
Absolutely. And we did talk about whether or not networks would be pushed into, or practices would be pushed into using this, and this would be the kind of route of referral almost by default. But then the other question is obviously what happens if or when the funding runs out? Is that going to change referral behaviors again because the funding is gone?
That's true. I mean, of course, as you say, we discussed that ICBs might change the pattern with which we interact with secondary care anyway, and then you'd be a fool not to sign up for this service and get some sort of recompense for following referral or interaction patterns. So yeah, that's one concern potentially around this. Gandhi, another concern that I have that we've spoken about before is, okay, the payment is £20 for the advice and guidance, but there actually might be work or activity that is suggested as part of that advice and guidance for further management in primary care that might have previously happened within secondary care. So there might be some work transfer, and it's not clear to me whether £20 on average will cover the cost of transferred work.
True.
So I think that's something everyone needs to keep their eye on.
Absolutely. But if you want to know more about that, so we did cover this not only in a previous episode, but also in our massive GP contract episode that we did that was just bonkers in terms of how long it was, but more importantly, the content and stuff that came into that, because that's where we went into the fine detail of the actual contract. So make sure you do check out that episode. And I think we have timestamped it now, so that should help navigate you to the right parts a bit quicker as well if you want to. Shall we move on to the next story?
Yeah, let's move on. Although there was just one final thing, because we'd done the maths, because I always think, how much is this worth for engaging with my practice? So a 10,000 patient practice, this is potentially worth about £13,800 is what we calculated.
Is not an
If
insignificant. I mean, that's half a receptionist potentially, or three-quarters of a receptionist, depending on how they're working and things. It's
particularly, yeah,
a
and
GP
particularly if
session.
and if it's activity that one GP session a week, not to be scoffed at, and it might be activity that you're sort of compelled to do anyway. I
Mhm.
wonder. So we'll see where all of that lands and watch this space and have a look back at previous episodes. The next story is from our friend of the EGP Learning Pulse. ICBs told to my new GP practice dataset for unwarranted variations. So I'm interested to know how you feel about this, Gandhi. So this is a story picked up by Pulse. I think they've been passed some information, some papers from a public meeting of Cheshire and Merseyside ICB, where they've talked about direction that they have received from NHS England on the use of this data. So NHS England has asked ICBs to use a new national data set to compare GP practices in their area and tackle unwarranted variation among them. So there's an implication of some contract management using this data. NHS England said in January that all ICBs are expected to put in place action plans by June to improve contract oversight, commissioning and transformation for general practice. And the new national data set will be used for this purpose. And then within the documents, they talk about a dashboard, which is expected to be live within the next month, that looks at several things. If we just scroll down, so these are the things which will be on the dashboard. There might be more, but there's number of general practice appointments per 10,000 weighted patient population, proportion of GP appointments within 2 weeks, percentage of patients describing their overall experience of the practice is very good or good, percentage patients describing their overall experience of contacting the practice as very good or good, emergency ambulatory care sensitive admissions, ACSs. Not exactly sure what would count as one of those, but they're measuring that per 1,000 registered patients. I think that might be walk-ins, emergency departments, potentially with that word ambulatory. All A&E attendance rates, cloud-based telephony will be included. So that's interesting because I think the government previously said under Amanda Doyle that cloud-based telephony would they said, I think they said there will be absolutely no targets associated with it. So it's interesting that that may appear on a dashboard with the intention to be used in contract management. And then the number of Pharmacy First common conditions referral per 1,000 registered population. So these are the sorts of things that we might be ranked on and compared with our peer practices on. So, I mean, how do you feel about that, Gandhi?
So it's very much system originated metrics, isn't it? It's designed to give you an idea of how general practice is integrating within the system and the impact it's having on the system. Not much of it to me says about patient experience, apart from obviously the ones around the friends and family scheme. But again, is that a valid metric to use in terms of how people engage with things? Because is that based on positive versus negative bias and that kind of thing? But I think in some ways I'm finding it hard to say that these aren't a good thing to look at, because at least it will help to give some standardized information about how practices function, rather than a lot of the other metrics that we've used in the past. For example, we've often talked about how the GP survey is not the greatest metric to use to compare practices. However, that's often what is used. We've also talked about how GPAD is really bad at telling you appointment activity and stuff. And yet again, that's one of the ones that's used. Whereas these pieces of data are slightly more objective. They're still not great, but they are better, I think, than some of the ones that we've got access to or currently used by the media in particular. Your thoughts, Andy?
Yeah, so I think the question is, I think we've gone past the point where we're having the debate about whether practices will be compared or ranked, or whether people will look at this data. And I think that happens, and it's difficult to say that that's not a good thing, actually, ultimately for patient care. I think the question is whether they're selecting the right metrics. People will always optimize for what is measured and what is valued by the system. So you have to be very careful what you decide to put as the key metrics. You're right. There's a real focus on the impact that general practice has on the rest of the system, and also about, I think, access in general. And I think it's interesting to see what isn't there. So we don't have kind of quality measures there. I guess we still have QoF, but QoF has been reduced, and there's been a general trend to reduce QoF and reduce IIF over the years. So I worry that there's maybe not the emphasis on quality. I also think that context is important. So I think these things need to be looked at within the context of deprivation, of availability of workforce, and the other pressures that are not the same across general practice. Not everybody's figures should be expected to be the same. I guess they can compare with peer practices, but I think we have to be really, really careful about that. And also, I wonder what the consequences are. Whether practices are going to be supported and there'll be funds available to support practices who aren't meeting these metrics, or whether there'll be more punitive contract management measures that go into place. So I think we need a bit more information really about how it's using, but it's an interesting early sort of indication of what might be valued by the system going forwards.
Absolutely. And I agree, context is definitely needed. So, for example, the number of general practice appointments, does that mean GP appointments? Does that mean total appointments altogether? How's the differentiation between telephone, online, face-to-face going to play into that? And even like the attendance rates at A&E, how much of that is then moderated based on your geographical location close to an A&E department, which will significantly change the way that people use A&E departments close to a practice area and stuff. So I think there are some modifications. I think they're hoping that the natural variation that may happen in terms of geographical locations of practice will have some modifying factors. But I know for a fact that my practice, for example, has very limited access to the pharmacy first schemes, whereas the practice a little bit further down the road, because of the number of patients going to the different pharmacies, actually they do. And we can't convince our patients to go to those pharmacies. So actually that has an impact in terms of how we can do that. And that's beyond our control because it's based on other people's service provision, not ours.
Absolutely. So context will be important. And I've no doubt we might see some lazy Daily Mail or local press articles that ignore the context in which practices operate and give us sort of these plain rankings. And it's always unfortunate to see the data used in that way.
Before we go to our next story as well, I know Andy's already got it queued up, just a shout out to Amar Ahmed. Welcome to the stream. As everyone else is joining us, feel free to say hi, and we will absolutely bring on your comments and stuff to say hi, we're back and things. But yes, Andy's already got our next story up and running, and I've called it the NHS barcode. Surely that's got to be the name for it.
Yeah, well, it's as good a name as any. I think that this is actually quite a positive story. So so let's start with the problem. Okay, so you've probably experienced this and spoke to patients who are having this problem, but letters coming out from secondary care in particular can be quite delayed. And there could be a number of reasons why that is, but often it's the post service. I do hear from patients who get a letter about an appointment that was the day before, or just in the next few days, and they can't make arrangements to attend the appointment. They're just getting their post too late. And this has been recognised by Health Watch England as well, with their chief executive saying that 1 in 5 people receive an invitation to an appointment by letter or text after the date of their appointment. So that's 20% of people have experienced that they've spoken to. So that's ridiculous, and clearly there is a problem. So what's the solution? So NHS has been talking with Royal Mail, and they have secured a deal. So interesting use of the word deal. That implies maybe they're paying for it, but a deal for an NHS-specific barcode that can be applied to NHS letters to ensure appointments and results are delivered on time, or at least prioritised above other mail. So I think that's actually quite a positive thing, really. I mean, late letters, it produces risks to patients. I guess it costs the NHS money if people don't turn up to appointments and they haven't had the opportunity to either cancel or rearrange if they can't attend them or just didn't know about them. So sounds positive. Thoughts, Gandhi?
It does. I think it's interesting that they're looking at, like you say, what does that deal look like, and how much of a difference does that give in terms of the differential cost and things. I guess the key thing I still want to know is whether general practice will be included in that, because general practice is not considered part of the NHS according to the government. So therefore, when it comes to postal systems, it will be considered part of general, the NHS, and be able to access and use this mechanism. And that's especially interesting when we're moving to this weird place that we're going to with general practice about how we communicate with patients, particularly given the SMS cost challenges that are now facing many practices as well. So are we going to see a shift back towards paper if we've now got another system that is costed more effectively? Interesting.
It's unclear how this deal is structured and whether general practice is included in the deal. That's not clear from the article. I suspect it won't make mailing out to patients cheaper than sending them a text message. But you're right. You know, actually, how we communicate with patients is changing, and I know that we're using more text messages. And you're right in identifying the cost of text messages is a bit of a thorny issue in terms of where that cost is borne or paid for within the system. But on the whole, I think that this is positive, and I'm pleased to see it.
It's interesting. We talking about text messages. So I've just messaged Andy. So I don't know if he's seen it or not. But I kind of wanted to show something that I have created for those of you. So those in general practice know how much of a problem this is becoming and going to become in the coming months and year or so. But actually, the cost of SMSs is rapidly becoming one of the biggest challenges for general practice budgets, and particularly with ICBs having to bore the cost of paying for the communication methods. So actually, one of the things we're going to now see is this challenge of how do we fund it, and many places now looking at how they use SMSs, and that's why I'm kind of interested in this, because I think this will be a compounding aspect to it and see how much difference this makes. Additionally, the cost of SMS has just gone up this year as well, which makes it even more of an impact. But yeah, so Andy's just showing this brief little video that I've created. If you do have the chance to watch it, feel free to do so. It's 8 minutes on telling you in your practice how to basically reduce the cost of SMSs that you're using in practice.
That's good. We need to take a look at that in my practice. I guess are you using AI to shorten text messages? Is that
that's part of it? I've actually created a shortener for people to use, and the link to that is, I mean, it's completely free to use, I think, if you've got ChatGPT. But yeah, you can then use that to shorten messages, but also some other tips and hints and stuff that will hopefully minimize those costs for both your practice and the ICB.
Oh, fantastic! Good resource. Thanks for pulling that together, Gandhi. So let's keep moving, I guess, through these stories. So many people will be aware that as part of the resolution of the industrial action between GP practices, general practice, and the BMA's GPC and the Department of Health was the agreement that there would be negotiations for a wholesale new GP contract next year. So in a meeting last week, a webinar, which I didn't watch, although someone has screen grabbed from the webinar to give us an indication of the sort of timeline that the BMA would like to follow in terms of the negotiation of that new contract. So it's just a quick story in Pulse having a look at that. And it looks like the BMA are keen to try and agree a new contract by July, December next year. So this green area is where they're aiming to negotiate the new contract. It's interesting that their aims go past April, which I think is interesting to note, because normally we would be moving on to the next contract in April next year. And in the text of the article and within the webinar, they were talking about possibly negotiating this as late as 2028, but definitely aiming to get this done before the next general election. So that's quite some time away. So,
which is interesting, because I think a lot of people anticipated that this would actually be the thing for next April, for April 2026. But that timeline definitely suggests that it's not necessarily the goal to have it ready for April 26.
Yeah, I mean, it's interesting to look at the timeline though, because it shows some other key things that will happen over the next year as well. We've got the spring spending review. We've already had the autumn statement, moving into spring spending review or spring budget. NHS 10-year plan coming out in the first half of this year. Window for Treasury to give a green light. Okay. Demise of NHS England running across the next 2 years, I guess. Doctors and dentists review board results expected over the summer, and then this large window to negotiate a new deal running through to actually July, December next year. So interesting that they feel that it could go as late as 2028. So we'll just have to keep watching this space. So later within the article, they were recapping some of the committee's sort of highlighted sort of needs or priorities within the contract. So it's interesting just to reflect on those. To restore core GP funding. So further improvement in core GP funding to to levels sufficient to meet the needs, to focus on continuity of care. We've heard a lot about a measure of continuity of care, but we haven't seen that actually come through in any contractual way, unless I've missed something, Gandhi. I don't know if it's alluded to in the documents, but we haven't seen a formula yet. So that's something that is on the BMA's wish list, to wrap neighbourhood care around the practice and its registered list, which I think is an interesting aspiration, and maybe speaking to the relationship between the primary care network, direct enhanced service, and associated payments and GMS, and how they're currently separate, and maybe connecting those in more of a way. I don't know. I guess we're reading the rooms here.
Yeah, and I think hopefully we'll get some more clarity in terms of what they're thinking. Obviously, we did have the special LMC conference that was just a month ago, and on the back of that, we had that commitment that we would have a negotiated contract, and obviously that was the key blocking point to having an agreed contract, which is what we now have. So we need to see how that develops.
Yeah, and the two remaining things were they want to push the government to agree to a full reimbursement mechanism for salaried GPs as per the old Red Book GMS contract. So that was, do you remember the Red Book, Candy?
So it's a mythical Red Book. I've never seen it, but absolutely heard about it for many, many years, because actually that life apparently was so much easier when we had the Red Book as the method of call.
Yeah, so I believe that the system was, if you had a salaried GP as a partner, then you could claim for that person's wages. I think it sounds a little bit similar to how actually we pull down money for the ARRS staff within primary care networks, actually, that you draw down the wages for people that you employed to deliver care at your practice. A lot of people hark back to those days. And also not holding on to things that are potentially bad for us, citing the risks around unlimited liabilities within the partnership model. Yeah. So I'd certainly welcome that being sorted out as well.
Absolutely. I think many people would, because it's a bygone era issue that it's so archaic. I believe general practice, general practice is one of the only unlimited liability partnerships still in existence, isn't it? I think that, and there's some weird law ones, but they're in the minority.
Yeah, most law firms operate as limited liability partnerships, so they have limits to their liability. They're LLPs, and your big accountancy firms and consulting firms run in the same way. So why not general practice? So good on your BMA, and that's something I'd certainly applaud if they're able to get that through. So, but Gandhi, we've reached about the midpoint.
But we've got a comment as well, Andy. So just from Wilmslow GP, have GPs been stitched up like kippers again? Everyone else seems to have negotiated great deals. Well, apparently Birmingham-based bin men still have yet to negotiate a great deal, as evident by my recent trip there. But I think there is
hanging on in there, though.
Yeah, I mean, they are definitely in there for the long haul, aren't they? But it does seem like other places seem to have negotiated fairly decent. I mean, you look at tube drivers and stuff. Oh my gosh, we really need to get their negotiators to help us out and stuff.
Yeah, junior doctors, consultants. I mean, arguably they got better deals. I guess the current deal is a put on, and we're hoping for the better deal next time. But we have stopped doing our industrial actions, haven't we? So
we have.
Time will tell, but you might not be wrong, Wilmslow GP. Let's see what happens. So Gandhi, we're about midway through. Actually, we're well over midway through. But we have a new thing.
We have. So here it comes.
So, Gandhi, while we're taking a break on the sofa, I've got a question for you.
Okay.
Our practice has been looking for ways to make things run more smoothly, better, more efficiently, improve patient care, and ideally to make a little bit of extra income as well. And I was wondering if you found anything that actually helps.
Yeah, so we've been in similar situations. Managing long-term conditions taken loads of time. So, there are various tools out there, and the one I would definitely suggest to have a look at is Primary Care IT. It's made such a difference.
And so, that's interesting. How does it fit into and work with your existing systems?
Well, that's the cool thing. It integrates with all the clinical systems that we've got currently. So TPP, EMIS, and Medicus as well, if you've got access to that. And they work really well rather than adding that extra step, because you can launch them through the systems.
And I've heard about the QRISK-3 calculator. Do you use that?
Yeah, so I know it's already built into EMIS, and they're looking at TPP integration soon. And then the benefit of having that straight away is the fact that, it's integrated straight away. You can get the risk scores without having to switch back and forth between all the websites and the other kind of tools and stuff that takes so much longer.
Oh gosh, that is a headache. So I'd love to avoid that. Sounds really useful, but what about support? New tools can sometimes be more hassle than they're worth.
Definitely, but I think their support is really solid. They have loads of onboarding to support that you can have, webinars, resources that you can access as well through their website as well, and regular contacts that you can use.
That sounds really good. Sounds like something that we'd be interested in as a practice. How would we get started?
Well, I'd definitely check out their website. It's primarycareIT.co.uk. That's basically where you get all the information you need, their contact details, as well as demonstrations of what they can do for you in practice, and also what's coming soon as well.
Oh, fantastic. We'll get started.
It is fantastic, isn't it, Andy?
It is. And Wilmslow GP as well, just commenting, oh, we've just switched to PCIT and it's brilliant. So thank you.
Definitely. So we've got some more news stories to come, including an interesting one in terms of a GP premises shift is what I've called it.
Shift. Okay.
Yeah, shifting. Where are we shifting to, Andy?
We're shifting to large American companies, in fact, huge American companies. So this is just picking up on that trend for let's call them assets, I guess, but parts of general practice and primary care being bought up by larger multinational, often American entities, and just really acknowledging that it's happening. And then I'm keen to sort of just explore what we might think about that actually. So what's the story? So the property investment developer Assura Health, they own just over 600 buildings within primary care in the NHS. Most of them are GP practice buildings. And they have announced recently that they've reached an agreement for a cash acquisition, which is interesting. Not receiving shares in return, they're receiving cash by US investment firms Kohlberg, Kravis Roberts, and Stonepeak Partners LP to purchase their assets within the UK. So that's those GP premises being taken over by these really big companies. I always like to have a look at who these companies are. So KKK, Kohlberg, Kravis Roberts, KKR, sorry. They've got assets under management of about $640 billion. So they are really, really huge. And they've partnered with Stonepeak Partners LP, who are not as big, $71 billion of asset under management. But they're really, really big. And I remember seeing Assura, I think it was Assura Health at various conferences over the years. And it used to be a popular sort of exit strategy for perhaps GP partners approaching retirement who were looking to release equity in their property. Perhaps they were struggling to get new GP partners to buy in. And often a route was, you can sell the premises to Assura Health, and they take the notional rent that goes through. You pay them obviously the management services and costs, and that removes the headache of having to manage your premises, and also release some equity as they paid you to acquire the building. But obviously that's all been now sold on to a large American company. I guess this comes at a similar time as some other things have been sold. So we were talking about EMIS being bought by large American company, ultimately tracked back to, I think, United Health or Allied Health, like the really big one. And of course, last year, a UK-based hedge fund bought ARRS Health's UK-based general practice business. So it was 80 medics and I think sort of 60, 70, 80 plus GP practices were sold to them last year as well.
So originally it was from 80 medics to ARRS, and then ARRS sold their port onto
HCRG Group.
That was it. Yeah.
So interesting, but yeah. Go on.
Like you said, Andy, definitely a trend for buyouts now seeming to come towards general practice. I mean, this is stuff we've seen, mainstream media for many companies. We've seen the big ones of things like obviously WhatsApp, Twitter, buyouts, all that kind of thing. But it does seem that there's this amalgamation happening between different providers. I don't know if you remember, it was one of my predictions I made a couple of years ago that this would start to happen when we did our annual predictions kind of episode. And I think, like you said, this is not the end of it, but it's interesting at how big a deal this actually is.
Yeah, and is this a problem? I would ask, because I guess some people might say, well, actually, one of the problems that we have with premises and estates is that we can't invest in them. We can't, the Department of Health struggles to keep them updated, to keep them relevant. And actually, maybe these investors have deeper pockets to invest in premises and facilities and keep them up to date. That would be the optimistic angle. I guess on the downside, will they increase management costs? Will they ultimately bargain for increase in rental costs to the government? So they've got quite large portfolios, so they've got quite a large sort of negotiating heft. So be interesting to see. You got any other thoughts, Gandhi, on this one?
No, just curious to see who's going to be next, to be honest.
Any predictions?
I don't know. Apparently, Accurate's making a big announcement in a couple of weeks' time, so you never know. I don't think that's what the announcement's going to be. I'd be interested to see if that was the case, but they are apparently making a big announcement in 2 weeks' time, so we will see what that looks like, that's for sure.
Could be. Okay, but interesting trends to continue to watch. And now we can move into our final story of the evening. And again, over time, we've been, in fact, was it just before Christmas, just after Christmas, we were checking in on the number of ARRS GPs that have been hired. So last year, there were discussions and talks about GPs being underemployed, particularly newly qualified GPs. There've been an increase in training places, but not really an increase in the funding available to employ GPs, leading to many GPs being out of work or underemployed. Some reports of people working in Tesco or working as Uber drivers after qualifying as GPs. And part of the response was for general practice to many people sign a petition asking for GPs to be included in the ARRS scheme. So to be possible to use ARRS funds through the primary care network DES to employ GPs. And the government did permit that to happen and have continued to. We've talked a lot about the mechanisms and the funding in other videos. But one of the questions we had was actually, how successful is this scheme and are people being employed? And NHS England were a little bit slow to release information, but they have released data now about the number of GPs being employed on the ARRS scheme, which is great. And the figure is, between 1st of October, 31st of March this year, a total of 1,503 individual GPs were hired. So that's individual GPs with discrete individual GMC numbers have been hired on the scheme. The government's goal was to recruit 1,000 GPs. So by that measure, it's been a success, I guess. And they've said, but within the data, the full-time equivalent GPs that have been hired are 851, which still is close to the 1,000 actually. So how does that strike you, Gandhi?
I think it's probably a marker of if things have been done differently or how they are currently set, I think it would have been considerably more successful, because we know that there was a very slow start to this. So if you go back through the episodes that me and I covered on, it seemed to be, it was very slow, very gradual, and then ramped up in towards the later parts. And now obviously the reimbursement for these ARRS GPs is more on par with what seems to be equivocal pay for GPs when they start working and things. So I think that has enabled it to be more effective. I think in terms of the numbers, it's always a positive news story to hear that people are finding work now. That has been one of the real challenges. And if this is a mechanism which by that helps people get into work, I think that's a great thing. Conversely, I know my subjective aspect of this is finding people for this role is really hard, like really hard.
Yeah, I would say so as well. And I guess the problem and the GPs who are struggling for work, they must not be distributed evenly across the country, or there must be areas where the problem is more acute than other areas, I guess. So maybe there isn't, well, maybe there wasn't enough flexibility in terms of being able to, only recruit a certain number of hours or GPs on the initial scheme, although they've removed the ring fence, haven't they? So actually those areas where I guess there are GPs looking for work and there's a need for them, they can recruit more of those GPs. So that might actually reduce that kind of mismatch that we're experiencing potentially, I guess.
We will see. Yeah.
And just interesting it's interesting to just kind of dig around what's beneath these stories. And I came across, if you click through, the government actually releases quite sort of good quality data about staff employed by primary care networks. So if you sort of click through to the story about the GP additional roles reimbursement scheme, you can actually click through and have a look at the because there's quite good reporting, isn't there, of primary care network employment, because people have to claim for the specific staff that they're employing. So actually the Department of Health knows exactly what's happening with the workforce. Might be something to learn in terms of that idea about the return to red book style claiming for staff on the GP contract. They certainly get better intel about who was around and working and where they were working, which is interesting to see. The makeup, say, of the clinical directors, actually. So we've got of 362 clinical directors, 296 are
full-time equivalent
GP clinical directors, 10 full-time equivalent nurse directors, which is interesting. 15 full-time equivalent direct patient care clinical directors. So I guess that must be other people like pharmacists. I'm not quite sure what they're driving at with that, but I imagine it's people involved in direct patient care. And then 42 non-clinical directors of primary care networks, which is interesting because I thought at least initially it needed to be a GP. But I guess there might be co-directors in here or people sharing roles.
Possibly. I'm curious to know about those, actually, because you're right. I thought that it had to be people working within the PCNs. That was one of the requirements.
Absolutely. I mean, I wonder if they're practice managers who are kind of supporting as
possibly,
co-directors potentially. But just interesting. So if people are interested, click through, have a look at this data. The other thing that was linked to that was interesting, and I guess I need to zoom in here.
Yeah, just a little bit, Andy. That's a bit tiny there.
Just a lot. Okay. So this is the headcount for GPs under ARRS by ICB, which is interesting. So, and again, you can access this all through, start with the Pulse story and click through to the resources and you will get here. But if you look at our ICB in the Midlands, where are we? Nottingham and Nottinghamshire ICB. So we have 24 working across our ICB, and we'll have probably 40 practices. It's quite a lot of practices. So it's not a huge number of.
No, so Andy, that's the ICB. That's not the city part. Remember?
That's what I mean. Sorry, there's going to be 60, 80. I think it might be about 80, maybe more practices across the ICB. So we probably have fairly low uptake in our area. Oh, actually, looking at the figures, pretty middling. But there are some areas like Manchester where 143. I'm not quite sure of their size. Greater Manchester ICB sounds big, but some of these, there's a lot of variation in terms of the numbers of the utilization of the scheme across the different ICBs. So let's get back to Brave browser, and I mean that's the end of the stories. I don't know if I've had any more comments come through.
We have. So Shankar coming in with, downside is less investment as such companies need to generate profits for shareholders. So that was back to our story about Azura being bought out and the impact of that. And I guess that's always one of the concerns that people have when there are buyouts. Is it about profit, and how do these providers then make profit on the basis of that? Good point. Also coming in with an extra comment from Shankar, although it seems like the ARRS announcement is leaking everywhere. Feel free to share if you want, Shankar, I guess. But so Andy was just about to show some other stuff that we've got coming up. Just to mention, I will be at the ARRS conference. If people do want to come and join, I'm actually doing a live podcast, I believe, there. So the links, I don't have it here, but we'll put it up afterwards if you want to join. But it's a free conference to attend. That's on the 29th of October. However, just before that, we've got a couple of other conferences you may want to come and join us for. So we've got our own PCN Plus conference, which you can't register to join us with because it's been sold out for like 4 weeks now, hasn't it, Andy?
It has, but you can't come face to face. You can still join online. If you register for online access, you will have a similar experience to people in the room. You'll be able to see both rooms. You'll be able to attend the sessions. You get an enhanced experience because you can use the online networking tool and have sort of a chat roulette chat network experience with other online delegates. It's going to be, and everyone, whether you come face to face or whether you attend and watch online, you can watch all of the videos from the conference again afterwards. So it's going to be a really, really good experience. We're doing this in collaboration with Ben Gowland of the General Practice Podcast and Tara Humphreys from the Business of Healthcare podcast, big stars in the general practice podcasting world. And it's all about really the future of general practice, isn't it? I think it's expanded a little bit beyond primary care networks this year. Would you say, Gandhi?
Absolutely. So we're going to be talking about various different aspects, including neighborhoods. We're going to be talking about modern general practice. We're going to be talking about how to manage your finances for PCNs. We're going to be talking about what the future PCNs actually potentially looks like. So if you do want to join us, feel free to do so. Those are the links there, as you can see, in terms of how to join. So bit.ly/PCN plus 2025. Weirdly, the PCN PL of plus is capitals and the rest of it is lowercase. I'm sorry, I screwed up when I typed it, but it got stuck. And 2025 at the end of that. And like Andy said, you can join up and get the recordings by doing so for that conference.
Yeah, you don't even have to attend online. You could sign up and then watch the recordings afterwards. It's this Wednesday, 23rd of April.
Yeah, absolutely. And then following that, just a few days later, we've got our other conference that me and you do, which is helping train trainers to train trainees, as I like to call it, or as its better name is GP5T. And it's the 9th one we're doing. We've been running this since COVID kicked off. And we've got an amazing lineup, haven't we, Andy?
Yeah, there's some great sessions. So this is, I often see this as the kind of softer side of training. I'm not a trainer, but I do educate medical students, and actually I get a lot of benefit out of this as well. So, you know, if people are in a similar boat to me, I think this is still something that's useful to attend. The sorts of things that will be covered are helping registrars navigate complaints, helping trainees navigate medically explained / unexplained symptoms, unhealthy perfectionism, how to handle perfectionist students and trainees, AI in medical education. Had some great sessions on that in the last few conferences, actually. There'll be an opportunity to ask a panel of speakers anything at all, ideally about training GPs, but the offer is to ask about anything at all. What does competent really look like? There'll be an exploration of what makes a competent trainee or GP, and then inclusive beginnings, empowering supervision, and then of course there'll be a close, and often there's a prize for the best networker and so forth. So all fun and games. That's just online, isn't it? And
that is just online.
Saturday morning on the 26th of April.
So if you want to come and join us at either of those conferences, feel free to do so. The links will be down below once we've finished recording this episode. And as ever, we'll be here to try and help navigate all the craziness that's going on in general practice. As Andy mentioned, we're still anticipating the 10-year plan. You never know, that may drop, and you know that me and Andy are definitely going to cover that when that comes out. And as ever, we'll be here to help tech and answer your primary care and learning. We'll catch you in the next episode.